All right, our next speaker is Dr. Sharon Chen. In the interest of time, she has a very nice bio here, but I will just briefly mention that she's a professor that's coming from the University of Sydney, and we'll be talking this morning. So
Thank you, Dave. I hope I can work this. Okay. Well, good morning, everyone. And I'd like to thank, firstly, Peter Pappas and his team for the great privilege of being here today. Also like to thank John Badley, who spent a lot of time helping me put this talk together, but sadly he's not able to be here this morning. So I'm going to talk about epidemiology, and these are my disclosures. It's nice to see mycology getting all this attention, even if it's among the converted. Usually when I give a talk on fungal infections, half the faculty goes to sleep immediately. It's just the way it is. So I'm going to talk about epidemiology today. And in trying to put this talk together, I thought I could review all the epidemiology papers, but even then, it would be just scratching the surface of the topic. So I thought we might think about it as a series of rolling epidemics, of overlapping epidemics on the background of endemic smoldering infection. So we have the era before AIDS, then we had, obviously, AIDS was a major factor in epidemiology, cancer, transplant, and apparently normal host that we've already heard a lot about from Peter Williamson, and whether these risks impact on our workup of patients. We could talk about C. neoformans versus C. gattii, and I'd like to finish with some observations from the MSGERC study, which is headed by Peter Pappas. So for the third time this meeting, here's Otto Buser and Abraham, who described the first case of neoformans in 1894. And in that same year, Sanfillis in Italy isolated the yeast from peach juice, and their work was acknowledged in a publication in 1994. Other first descriptions, here we have the first description of Cryptococcus gattii, an atypical strain, and it caused disease in a 7-year-old child in the Congo in 1970. And we all know now a lot about it, about its association with eucalyptus trees, which I shall not be talking about, and its association with koala bears. And there we have one such example up there. So the story of cryptococcosis historically probably began in cancer. We have very few incidence data before 1981. Relatively rare reports came up from the USA. But steroids were introduced in 1940, and its association with non-Hodgkin's lymphoma and Hodgkin's lymphoma. And this really stamped crypto's position as an opportunistic infection. And this predates modern immunosuppressive therapies, so well before we knew how to really immunosuppress patients. It was first reported in 1923 in a patient with Hodgkin's lymphoma, then known as cystic blastomyces. And there was a very nice series from the Memorial Sloan, reporting 47 cases, of which 41 patients had cancer, CLL, HL, CML, and multiple myeloma. Mortality rate was quite high, 67%, and this worried people because this was the mortality that was higher relative to AIDS. Let's fast forward to the late 1990s, and here are two more modern studies. The first was from the MD Anderson from Dimitrios Kontianos' group, and the second was a US multi-center study performed by Pete Pappas. So comparable time periods, patient population wasn't quite comparable. One was a cancer population, one was HIV negative population, as reflected by the underlying comorbidities. But what was obvious was that the relative proportion of patients that had steroids was high. So steroids may be good for treatment, as Peter has pointed out, but steroids also predispose to cryptococcosis. The mortality was not quite as high as that seen in the Memorial Sloan, so about 28 to 30%. In the MD Anderson, they estimated the cases were 18 cases per 10,000 fifth admissions, with a PM post-mortem prevalence of 0.2%. In the Pappas study, the mortality predictors were age greater than 60, having a hematologic cancer, organ failure. And this was in the era of azole use. So it all makes quite a lot of sense. Fast forward again to the present day, 2016. Here is a large systematic review published only this year of 583 adults of cryptococcosis in cancer. And the main conclusion was that it was kind of beginning to be like cryptococcosis in solid organ transplants and HIV patients. So we think there's an increase in incidence, but when you did the maths, the numbers were stable. But the authors concluded that it was probably too early to detect the real rise in incidence. And the overall one-year incidence was only 0.2%, representing 15 to 30% of all IFIs in cancer patients. So on the graph, if I can get this to work, here we have the blue dots. Okay. The blue dots represent the hematologic cancer patients, and the red dots represent the solid organ transplant patients, with the green dots representing the total numbers. So it's about hematologic malignancy. If you look at the data more detailedly, so of 459 patients, 377 had hematologic cancers, 92 leukemias, 206 lymphomas, and in the US, lymphomas represent 53% of all hematologic cancers. Of note, only 6 patients had a stem cell transplant, and 86 or 15% had solid organ tumors. There was a lot of information in the systematic review, and distilling it further, authors looked at the differences between hematologic and solid organ cancers and concluded that hematologic cancer patients were more likely to have disseminated disease and CNS disease. But despite all this data, the outcome data was very incomplete, and clearly they identified what they called an unmet clinical need. Turning to other groups and away from cancer, what about non-HIV and non-transplant risk groups before we get to HIV and transplants? There are a number of conditions that may predispose to crypto as well. Rheumatologic diseases, chronic renal failure, chronic liver failure, chronic lung disease, diabetes, and pregnancy. So all these things are kind of in the background, but we don't really know about the prevalence, and it's still a relatively data-free zone. These are the 4 largest studies I could find. The PAPA study, a study in Taiwan, a study in Vietnam, and an older study from Australia looking at some of these risk factors. Of course, if you have an immune deficiency from sarcoid, from any one of these funny immune deficiencies, hyper-IgM, receive MABs, and idiopathic CD4 lymphopenia, you might get crypto as well. But as I've mentioned, a relatively data-free zone and perhaps an area for further study. Okay, this was a systematic analysis of lupus patients, a pooled analysis that was quite recent, and it was identified cryptococcal meningitis in about 0.5% of SLE patients. Of these patients, 40% had lupus activity and 38% were misdiagnosed. They're mainly females, and the mortality rate was about 30%. And when you did the multivariate analysis, it showed that the prednisone equivalent of 30 milligrams per day led to a higher mortality rate. So again, the steroids have appeared, and the steroids have a recurrent theme in what I'm going to talk about later as well. Okay, moving on to cryptococcosis in organ transplants. We know a lot about this from Peter's Transnet study and OTIP study, and it's well documented that they cause about 7 to 8% of infection fungal disease in solid organ transplants. And there has been no change in incidence for the last 20 years. So lifetime and 12-month cumulative incidence is estimated to be 12% and 0.2% respectively, with a mortality rate of 14 to 27%. You might expect that the incidence may vary between the type of transplant, but it's actually quite similar. So lung and lung hearts, 2%, hearts, 3%, renal, 2.8%. I would have expected that to be a bit higher, and liver, 2.4%. The clinical features are varied and protein, and I guess depends on where you get transplants from. So in lung and heart-lung transplants, commonly you have pulmonary involvement. And Tom, I think, is going to talk about clinical manifestations in his talk. One of the questions that we often get asked is, how do these transplant patients get crypto? Well, they can get a primary infection or reactivation, or it can be donor-derived, including from corneal transplants and other eye transplants, or unrecognized pre-transplant infections, which is increasingly reported in cirrhotic patients. The median time to crypto is about 20 months, so it's quite far out, with a significant proportion more than 36 months. Some associations, I've already mentioned liver disease, failure, cirrhosis of viral hepatitis, the use of alemtuzumab and steroids, and the use of calcineurin inhibitors. And it's quite curious because the use of calcineurin inhibitors predisposes to skin or subcutaneous infection and or bone and joint infection in these transplant patients. Why is it so uncommon in stem cell transplants? Well, there's the prophylaxis theory. All stem cell transplants, at least in Australia, do get prophylaxis, and that could be one reason. But the basis of this relative rarity is not understood. And Nina Singh and Barbara Alexander have written that they think it is the thymic regeneration of stem cells after your transplant that protects from cryptococcosis. Most of disease caused in stem cell, in solid organ transplants is caused by C. neoformans. Many ID physicians also get asked this question about whether pre-transplant cryptococcosis is a contraindication to transplantation, and the answer is probably no, despite anecdotal reports of uncontrolled infection. I think a solid organ transplant and your stem cell transplant can be cautiously undertaken provided you have evidence of disease control, provided you have evidence of negative culture, stable or declining Crag titers, and it must be microbiologically eradicated. It's advisable to continue fluconazole post-transplant for a minimum of 12 months, although the optimal duration of secondary prophylaxis has not been defined. So we mentioned C. neoformans. What about C. gattii? There has been one report from Oregon by Graham Forrest's group looking at 11 patients with C. gattii infections, kidneys, livers, lungs, and heart. Only 11 patients. And again, the median onset of disease was long, was 18.8 months after transplant. Curiously, they found that disseminated disease was more common than disease in a single site. And this was caused at that time by the Oregon endemic strain VG2, which had high fluconazole MICs with a median of 12. CSF minimum had showed minimal inflammation with low Crag titers, and the attributable mortality rate was 36%. In Australia, gattii in solid organ transplants is very rare. I think we've only seen no more than 5 cases over the years that we have seen gattii infections. Iris, Peter's also already talked about, and this is a key point, not just in AIDS, but in solid organ transplants. And it's a great masquerader. It affects about 5 to 14% of solid organ transplant recipients, about 4 to 6 weeks after antifungals are started. And the diagnostic criteria makes sense. New worsening clinical radiological findings, you must have negative microbiology, and there must be no other alternative explanations. Obviously, one can do cytokine studies, look for host inflammation responses. These are very well documented in HIV patients, less so in solid organ transplants, but I don't have time to go into that today. Iris is more likely to occur in CNS infection and disseminated disease if it's present at baseline. And if you have a kidney graft, you're likely to lose your graft. It has been associated with the discontinuation, but not simply the reduction of calcineurin inhibitors. And therefore, one discourages the abrupt cessation of immunosuppressives. So obviously, you can get enlargement of brain lesions, worsening meningitis, worsening lung lesions, but also the eyes are a source of possible iris where you can get very, very bad inflammation and cause blindness in the patient. Okay, now we're turning to AIDS, and I'm going to talk only very briefly about HIV. There have been more than 10,000 papers published on AIDS, and I'm certainly not going to go through them. But the key advances are how common it is. in today's era with azole therapy? And do we screen for disease? And I'm sure Tom is going to talk a lot more about that. There was, I'd like to acknowledge one very nice study performed in France, the so-called AD study, which looked at cryptococcosis and HIV and compared it to non-HIV patients. And this was published by Françoise Dromer's group in 2007. And the main conclusions were that cryptococcosis was more severe in HIV patients, and that you could fail therapy at 14 days, particularly if you had disseminated disease, a high starting serum antigen titer, and a lack of 5-FC during induction. We know all this now, and this is their study in detail looking at differences between HIV positive and HIV negative patients, so 177 HIV positive versus 53 HIV negative patients, and in a nutshell, HIV patients were younger and they had more meningism, they were more likely to have blood culture positive disease and to have a higher serum antigen titer and to have higher positive India Inc. findings. To this day, this is still largely true. The burden. In 2008, in a nice paper by Ben Park from the CDC, he estimated just under 1 million cases of cryptococcal meningitis globally. Now, this will vary. It's highest in sub-Saharan Africa, and its lowest incidence in Europe and Oceania. 2/3 of cases died within 3 months, and in Africa, more than 80% died within 3 months. We've heard from Peter how the incidence in the US has declined, 5.8%. With a mortality of 12%. In Australia, similarly, the incidence has declined, but I'm actually embarrassed that I actually don't know the actual figure. Nonetheless, in 2014, we still had 40 million patients with persons with HIV, with 5,600 new diagnoses per day. Early diagnosis is the key. It must be done to try to reduce cryptococcal meningitis-related mortality. And here we come to screening using the serum testing. I've just got one slide. WHO, since 2011, recommends routinely screening by Crag titers if the CD4 count is less than 100. The IDSA guidelines suggest consideration for screening if the CD4 count is less than 50. We know from mathematical models that screening is cost-effective if prevalence is greater or equal to 2% because it saves lives. And this is a kind of cost per life saved line as opposed to a timeline, looking at the costs saved and the prevalence. And we can see that in Cambodia and in Cape Town in Africa, where they have high incidence, of course it's cost-effective. In the USA, the prevalence is about 2.9%, so it falls within the 2% recommendation, and it's still cost-effective. In the UK, the prevalence is about 4%. In Australia, it's probably about 4%. So for us, it would be, worthy considering thinking about screening, at least in certain patient populations. It does matter, so there have been a number of studies in Africa, in the US, in Thailand, and looking at Crag screening. And the largest study was the one by Meyer in Uganda, looking at screening versus non-screening. And they found that if you treated patients who had a positive Crag test with fluconazole, you could increase their survival rate. So it's considered to be cost-effective. What about normal hosts? Well, Peter's already talked a lot about this. This is actually a very, very old infection, and I acknowledge there are geographic differences. So in PNG, we know from small series that most of crypto occurs in normal hosts. A lot of cases in Brazil occur in normal hosts. And more recently, series in China, Taiwan, Vietnam. In Australia, from 1965 up to 2000, we've also noticed that at least about 20% of cases occurred in normal hosts. And normal hosts are equally affected by C. neoformans and C. gattii. Joe talked last night about whether it's important to speciate Cryptococcus and whether it's clinically relevant. Well, this was a relatively older study in Australia now, where we looked at 4 different groups: C. gattii patients, normal host patients, non-AIDS immunosuppressed patients and HIV patients, and 4 clinical entities, so CNS mass lesions, chest X-ray mass lesions, meningitis, and hydrocephalus. And you can see from the light blue bar and the dark blue bar that normal host and gattii differ relatively substantially from your HIV population, which is the light green bar, and less so with the non-AIDS immunosuppressed. So it may be relevant to speciate your cryptococcal species. Which brings me on to gattii neoformans. We now know a lot about neoformans. We know it's common, its burden is well described, it occurs worldwide. We know about its risk, HIV organ transplantation, its clinical features, which is largely meningitis. Diagnosis is not difficult. Screening is appropriate, particularly in high-risk countries, and we know how to treat it, and we have really good animal models. For C. gattii, stereotypes B and C, it's uncommon, founded by the fact that we have clusters rather than sporadic endemic disease. Clinical features do cause meningitis, but CNS, brain and lung infection are also very important. Diagnosis is not difficult. We don't know about screening, and screening is not done at the moment. And when we want an opinion about treatment, you ring Peter Pappas or Peter Williamson or John Perfect and all of you in the audience to get an opinion rather than by reading the textbooks. Now, we talked about the 7 species, so I'll be very quick about this. Joe's already mentioned that there's been a diverse taxonomy now, so the Vargrubii maintains its name as Cryptococcus neoformans, and serotype D is proposed to be called Cryptococcus D neoformans, and Cryptococcus gattii has a series of names. I once teased Sibrin about this, and he told me to lighten up. He said, clinicians all need to lighten up. And taxonomy is a dynamic science which cannot be muzzled by nomenclature protocols. So, take it. We should do what we believe to be right, and you can stand here with your hand on the heart to say this is Cryptococcus gattii, all the more better. Okay. So genetic types or groups of C. gattii, and again I won't spend a lot of time, with 4 VG types, each would contain serogroups B and C. At the moment, MLST, AFLP are the preferred methods, but whole genome sequencing and all the new techniques that we've heard about are coming into play. Very importantly, the types vary with geography and with ecological niche, and it's important for tracking. And therefore, all these serotypes and these species types are important in the study of epidemiology. Okay, moving on to C. gattii infection, and I know I'm running out of time. So C. gattii causes about 95% infections in Papua New Guinea, where the prevalence is 42.8 per million population in the central province. In Brazil, we also see C. gattii infection, although there are no precise incidence data. Children are disproportionately represented, as is infection in the north and northeast, as in the provinces of Amazonas and Para, Romania, Poi, and Bahia, which are shaded in the green there. Interestingly, it's the VG2 genotype that predominates in the north and northeast. How about in Australia? 2 national studies have identified an overall incidence of 0.9 per million population. And as you can see, the incidence is higher in the north than in the south. In 2000, all isolates were serotype B, mainly molecular type VG1. Most of the patients lived in rural and semi-rural areas, and Aborigines were predisposed to having gattii infections. We are very familiar with the Vancouver Island outbreak. You can see the incidence rising in 1999 from 5.8 per million population to 27.9 per million population in 2006. All the red areas in the panel on A are the human cases, the blue areas are the vet cases, and in the lower panel is the projected number of cases according to ecological niches, so where your Douglas firs grow and your western coastal hemlocks. Not good trees to stand under. Globally, this epidemic moved into the US Pacific Northwest, into Washington and Oregon, and more than 96 cases, but I have not yet seen any incidence data. And there has been an explosion of case reports also in Europe, in newly endemic areas and in non-endemic areas, and I've listed some of the countries where C. gattii has been reported since the epidemic. In Australia, we see at each institution perhaps 2 to 3 cases a year, so kind of a smouldering endemic, non-epidemic picture. In Europe, there have been more than 40 cases of orthogonal cases, also dormant cases, and an apparent increase in 1995, as identified by extended MLST typing of 100 isolates, of which there were human, animal, and environmental isolates, and also typing of isolates from the rest of the world. And the conclusions were that of the 40 human cases, 24 were acquired outside Europe, 16 were acquired within Europe and could be linked to environmental strains in the Mediterranean. And the conclusion was that you could either get de novo infection or imported infection, which might be dormant for many, many years. Okay, what about the host risk? So here are 3 studies from Australia, Canada, and the Pacific Northwest USA. There are some differences. So interestingly, 80% of cases in Australia had no comorbidities or immunocompromise, but the relative proportions were lower in Canada and the Pacific Northwest. So Australia is the endemic kind of infection bit, and Canada and Pacific Northwest are the epidemic infections. HIV infection was uncommon in all 3 areas. We saw 6 cases of idiopathic CD4 lymphopenia. Cancer was much more common in the North America than Australia, as was solid organ transplants and the use of steroids. So emphasizing the differences between epidemic infection and endemic infection. It's a nice study, a little bit old now, done from British Columbia, looking at a case control study and looking at risk. Oral steroids, odds ratio of 8.1. Pneumonia and other lung conditions, being more than 50 years old, having HIV, and being smoker. There's more data that's being distilled at the moment. Peter's also talked about host genetic factors, so I'll fly through this. We know there's a higher incidence in Australian Aborigines. We know there has been some work done on HLA-B 5601 status in Papua New Guinea. We've already talked a lot about the anti-GM CSF / gamma interferon antibodies. And Kieran Ma reported a case series of underlying IgG2 deficiencies in gattii infections. And this is just one table from the study performed by Jun Quan Chong's lab, looking at anti-GM CSF antibodies in plasma. So healthy patients from China had low antibodies, CNS crypto patients, these were all HIV negative patients, had intermediate anti-GM CSF antibodies, and CNS patients that were HIV negative from Australia all had higher levels consistent with what we've heard from Peter this morning. And I'm not going to talk about his study. So just to finish up, this is the MSGERC study. This was a multi-site analysis of Cryptococcus neoformans versus gattii infection at the UAB, Duke, British Columbia CDC, Oregon, Washington, and Sydney University. The breakdown of number of patients are seen there by institution. Overall, 835 patients, culture positives, neoformans 314, gattii 161. And there was some skew between centers of which variety they, or which species they contributed. So we had mostly CG cases, as did Oregon and BC, whereas Duke and UAB were nearly all CN. So these are the first results for host risk. Variables on the left-hand side, CN in the middle, followed by CG and the p-value. And you can see that there were some differences. Gender, more males in the CG group. Host disease, significantly higher proportion of CG patients had no risk factors, whereas the reverse was found for HIV, any solid organ transplants, including kidneys and hearts, all cancer patients, and non-heme cancers. And see that steroids still feature prominently, but there was no difference between the CN and CG groups. Clinical features. Disseminated infection more likely occurred with CN patients, as did blood infections, and interestingly, brain infections, but not lung infections. CN patients were sicker, the time to diagnosis was shorter, they were more likely to have chills, anorexia, nausea, and interestingly also altered mental status, but not fits. What about the CSF and imaging findings? This was CSF findings on 382 patients. Opening pressures were high, with a median of 280 millimeters of water in CN versus 310 in CG. Not significant. For what it's worth, the Gadii patients tended to have higher white blood cells, lower glucose, but similar CSF crags and similar serum crags. Imaging was variable. It's a retrospective study. Nonetheless, CG was associated with hydrocephalus, abnormal baseline cerebral MRIs, but not lung lesions, either multi or uninodular lung lesions. Interesting. Outcomes, nearly at the end. Mortality rate. So if you look at the 12-month mortality rate, you find that mortality rate was higher in your Cryptococcus neoformans patients. P is 0.01, both for all patients as well as for CNS infection and lung infections. Now this you might find curious, and we haven't done the multivariate analysis yet. But this is all CG patients in an epidemic setting and endemic setting, which may skew the results a little bit. Here we have the survival curve. So on the left-hand side is overall patients. You can see that the blue is C. gadii and the red is C. neoformans, and there was poorer survival in the C. neoformans, both for overall patients and for CNS infection. So the main conclusions for epidemiology: we know that cryptococcal meningitis and HIV/AIDS remains a global problem, maybe not in every country, but certainly in resource-poor countries. Its occurrence in other host groups are uncommon, but still significant, and steroid use is present in almost 40% of cases. Disease affects normal hosts, overall about 20% of cases. As for CN versus CG story, there are distinct differences in the onset of presentation, clinical presentation, host-related outcomes, and the outcomes of CN appear to be worse than the outcomes in CG. I've already commented about the skew, and we're working on to see whether we can further distill the data without weakening it. So the workup of patients, obviously if you have a patient with cryptococcal meningitis, exclude HIV cancer, other immune deficiencies, and where there's a way forward, we can do a fancy immune test as well. You must perform an LP in a brain CT MRI unless you're confident there's only extra CNS disease, like in an outbreak. When you do an LP, you must do a pressure measurements to exclude raised intracranial pressure, and blood cultures are helpful. So nothing that I've told you is new, it's all standard practice. Is there a need to speciate to the CN and CG level? I'd like to leave you with that. 5 years ago, I was convinced there is. 3 years ago, I was partially convinced, and today I'm not sure. All right, with that, thank you very much.